in the beginning of it kind of talks a little bit just about the disease process. So we will go over that very quickly because I think the audience is professionals and practitioners. So I like to just kind of start off a little bit about who I am. So I have a bachelor's in nutrition from Oklahoma State University. I have a master's in community health, and then I have a PhD in behavioral health science. So what that basically means is my PhD is sort of a merriment between public health and counseling and psychology. And then I'm actually just finishing up a dietetic internship through the Ohio State University. I have about 20 hours left out of a 1,200 non-paid program that I've done dual with my role at Children's and UAMS, and then I'll sit for my RD exam. One of the big reasons I did that was just to have the credentials to actually practice for this population, specifically muscular dystrophy, but Duchenne-Bekr. So those are my credentials, but then I have a whole nother reason that I feel like I'm very qualified to talk about these sort of things. This is Tyler. So he's the little guy in the wheelchair. Most of the early pictures where he looks younger, he's in his manual chair. And then as he's progressed, he is now 11. He'll be 12 in January. He has been in a power wheelchair for about 2 years, almost 3. And I was telling them earlier, Tyler has a very large deletion. So we not only have the physical impairments, but we have some cognitive and developmental issues as well. So Tyler, as you can see, is a fairly fit little dude. And part of that is because we are very stringent and we talk about his diet and his nutrition a lot. And that's kind of what I want to talk to you guys about today, the importance of practitioners talking early and often about this topic. So we're going to skip over what the overview is. You know, we all know what Duchenne muscular dystrophy is. We're going to talk about our signs and symptoms. You know, again, everybody here knows that we're going to look at that muscle weakness, and we're going to see that. And that's a lot, most times where parents kind of start to think, okay, maybe I need to go have him checked out. For instance, Tyler, we had taken him in at 5 because he'd had some issues before with some hearing delays and his speech delays, and just was a little bit, you know, clumsy, if you will. And we thought maybe there were some issues with autism. Took him into the Dennis Development Center, a program here at UAMS and Children's. And the psychologist that was testing him saw him do the Gowers movement and was like, nope, we think he needs to be tested for this. So send us over to genetics. So some other symptoms that we notice are enlargement of calves, the waddling gait, the lumbar lordosis, and then the heart and respiratory muscles and the pulmonary function decline. So we're going to know that the heart and respiratory and the pulmonary function are things that we can help keep them maybe at bay a little bit more with some good nutrition. So the diagnosis, the CK and other enzyme levels, genetic testing, which if you're not familiar with Decode Duchenne, please look them up. It's a great organization or a great program through the organization, and it's great for parents and as well as siblings that might have issues or be carriers or things like that. And then also the muscle biopsy. So this is a really, really cool cartoon that I have from Dr. Singh. She is a medical professional and she teaches at a med school, and she does these cartoons for all kinds of diseases, all kinds of things for her med students. And I love it because it's a cartoon. It gives you a little bit of fun kind of thinking about it. And it's a great way to talk about it in an atmosphere that maybe people are going to understand a little bit better. And then she goes on and she gives you a better view of what the topics are. So I think these are 2 great tools, and I have them in my slides. You can go and see what other things she uses. And I like it for parents because it makes it a little bit maybe easier to understand. Let's see. Okay. Uh-oh. What happened? Okay, so the causes. The DMD occurs because the DMD gene has failed to produce the dystrophin. And then most cases are caused by mutations. And there is the account that we call it the spontaneous mutation. But as we know, there was some type of mutation somewhere. Maybe it was a family member a long, long time ago that we didn't know had it, or we weren't even aware to what to be looking for. Well, let's see. I guess, sorry guys, I didn't realize I was not on. Let's see. Okay. Okay, there we go. So it is possible, you know, like I was just saying, that it was inherited, or it could be the spontaneous just happened with that kiddo. All right, so this is where I kind of want to get into what I'm here to talk about, the medical management. So in most of our clinics, I don't know how it works specifically in your clinics, but we usually have a neurologist, a cardiologist, a pulmonologist, neuropsychologist or psychologist. Then we also have rehab medicine, which is going to be our physical therapist, our speech therapist, and an occupational therapist. And then we have a dietitian, which we do not see every visit. And we, as a standard of care, and I will just go ahead and kind of speak for the whole standard of care in the US for this population, we don't utilize dietitians very well. A lot of times it's because we don't know we need to utilize them until it's too late. So also a lot of the research that's going on is in, you know, we're looking at gene therapy, we're looking at mouse models and regrowth and things like that. But you know what we're not doing? We're not really looking at very much information and research on nutrition, and specifically how that could affect these boys and their muscles and things like that. You know, a lot of problems with getting human research is compliance. And we are asking families to change a lot of things with this. You know, you're asking a family that maybe has been eating everything out of a box or a bag to changing to more of a holistic Mediterranean style eating pattern. So we need to focus on nutrition as a vital component of the standard of care. And I think this is what Kent and Kiera were also mentioning, is we need to start early and throughout the disease process. It's not just eat healthy. It's okay, know when to start implementation, know when to start the conversation about, hey, we may have to do a tube feeds at some point. Hey, you know, we need to talk about fluid. We need to talk about speech therapy. We need to talk about how, you know, the way we view food can be very positive or negative for that child. So this is what I kind of put together was nutrition and me. So these small changes for these big wins, and these wins are what I need to succeed. So what can we do and where do we find help? So we have weight management and health. And then that means we need to know how many calories our boys are actually needing and what they're eating from the get-go. So typically with the standard of care, with what we have been doing is have them see a dietitian at the onset of steroids, and then whenever or if we think they need it. And usually these topics of looking at caloric need are not even discussed. There's different ways we can do it. We can do it with just a basic equation that we can do in clinic, very simple, to kind of give parents an idea of what they should be eating, or their kiddos should be eating. In turn, also their families, because we're not going to ask these kiddos to change their diet and say everybody else gets to do whatever they want. And then also choosing the right size and the food portions. So what are we supposed to be eating, and what does that look like? You know, 3 things that I like to suggest are lots of water, because, you know, we need to stay hydrated, and water is going to make us feel a little bit more full. We have a whole lot of issues that come with asking them to drink more water, which I'm sure, you know, Kent talks a lot about. It's the more you drink, the more you have to go to the bathroom. So if you've already, if that is already something uncomfortable for you, or you feel maybe scared or apprehensive to ask people for help, that can be an issue. So what we see, these kids aren't drinking enough water and they're dehydrated. And then talking about foods with high satiety factor. So that means those foods that are going to keep us feeling full longer. You know, I love a good Snickers bar, but I know if I eat a Snickers, I'm going to be hungry in 30 minutes. I know if I eat an apple with peanut butter, I'm going to feel full longer. One of the things I always suggest is getting foods with fiber. So that means if you're going to eat an apple, eat that whole apple. Don't eat just the meat, eat the peel. And then also pairing a protein at every meal or every snack. And that could be some nuts and a cheese stick, or that might be the peanut butter on some whole wheat toast, or some crackers and cheese, things like that, where you have a little bit more of a rounded diet. You know, we can make it pretty simple if we just go back to the good old My Plate. And that's something we use here in the US of it's a grain, meat or a protein, it's a vegetable, it's a dairy, and it's a fruit. So those 5 food groups. And then everything we talk about with our kiddos and our parents, we can do from our hand. So our protein needs to be about the size of your palm. So, you know, somebody that's 3, their little hand is smaller than mine. So their protein needs to be this size. Our fruit and our vegetables and our grains, usually about the size of our fist, you know, that's a good like rule of thumb where you're not asking people to measure things. You're not asking people to count calories. And then also, you know, our dairy, looking at that low fat dairy. One of the things that we see in clinic is we prescribe vitamin D almost always with the standard of care. But a lot of times we haven't discussed the role of calcium with that vitamin D, which basically when you have calcium and you have vitamin D, they work really, really well together. If you don't have one or the other, they don't work as well together. So talking about getting calcium, I don't know how it is in Israel, but it seems like we have a very difficult time getting our kiddos to just drink milk. So, you know, what are other options that we can offer for calcium? That is cheese, that is yogurt, that is, you know what, if we have to do some low fat, low sugar frozen yogurt, if that's the way we're going to get some calcium in, okay. So just looking at some different options. One of the things we say basically just from the get-go, nobody needs sugared beverages. Just cut them out. That is the one thing you can do. Get rid of the Cokes, get rid of the sodas. Even with the milks, let's try not to do the chocolate milk. Let's pick white milk if we can. And then also, you know, really looking at the electrolyte balance and sodium balance with these boys, especially if they're going to have heart issues later on. You know, a lot of them start some blood pressure prevention and medicine early on. So watching those Gatorades and even like the Gatorade Zeros and things like that, because that can really mess with our fluid and our electrolyte balance. So we basically say water's the best option. You know, we can do Mios, we can do some Crystal Light, we can do some things like that, but try to just make some of those small changes. And that's pretty helpful. One of the things that's difficult with families is, like I mentioned before, we're not just asking, you know, we're not just going to say, hey, Tyler, you're going to do this. It's all right. This is a family. We're going to all work together, just like your care. Everybody's going to be a team. So, you know, if we're going to do this, we're all going to do it together. And by no means do I not let my kid have some Skittles or, you know, the buttery popcorn. We don't do it all the time. And it's a treat, you know, it's a treat for everybody. We don't, as a society, need foods that are from like boxes and bags. And, you know, I think with this different population in Israel, you guys might eat completely different, where going to McDonald's is not the standard for you guys. For us here, sadly, it is. So that's something we all have to work on. So the weight management, the health, the physician role, the dietitian role, and then the family role. That's kind of how I see it broken down. So we have the education, the weight management, and the health, and why we need to be doing this. And then our physician role or our practitioner role and our dietitian role. These people need to be working together. And then we have the family role. So this is just some brief information on codes to bill for insurance, because that's what my practitioners want to know. How can I talk about this and how can I get paid for it? You know, especially when you have 10, 15-minute visits. So number one, I kind of have done a little research with some practitioners. they don't feel comfortable talking about nutrition for several reasons. Maybe they aren't qualified. They don't feel like they have the knowledge. Maybe they feel very hypocritical because they don't eat this way, or they are overweight. So that's been a barrier to have them address this issue. Some of them don't even see the need because the nutritional status is not in their mind at the forefront of an actual physical problem. So some diagnosing nutritional problem tools, I just have some websites that are pretty easy to get to. And it's just to give you an example of there are different things that we as dietitians need our practitioners to diagnose. So dietitians in the US cannot diagnose disease. I don't know if it's a little bit different in other parts of the country and other parts of the world. But some simple things we can do is looking at growth curves. So if you have a kiddo that falls below that 5% or above that 85 percentile, we have these codes for it. We have codes for things like osteoporosis, osteopenia, sleep apnea. A lot of our kids, like we were talking about, are on BiPAP or CPAP. So we can look and relate nutrition to those issues, which again, gets everybody paid. Pre-diabetes, we have a lot of kids that are on metformin. So obviously if they're on metformin, there's some diagnosis, or there's at least some issues with blood sugar, fasting blood sugar, A1C, things like that. And then we have some weight management issues that we can look at. So some of these are for adults, but then we also have some children. And if you will look at this, obese due to excessive weight, drug-induced obesity. So you can actually link that to steroid use every single time. So that's a good one to kind of keep in your pocket. If you can't think of anything else, we do know that steroids that can cause weight gain. So that's something to think about. And then anytime overweight, you have it. Anytime you have the different BMIs, you have it. So we have some great tools to use. And then just one more, the dietary counseling and surveillance, no specific diagnosis. So as a practitioner, if you think, this kid and this family could definitely use some guidance, there you go. It's kind of the blanket catch-all. Insurance is difficult sometimes. So, the best thing you can do as practitioners for your dietitians is give the dietitians a reason to be there. And that means coding it correctly and making sure that you know what diagnosis that dietitian needs to take care of these kiddos. Okay, so when to ask for help, when to see a dietitian. Typically, we've done at the onset of steroids, but I think a lot of people will agree that it needs to be a regular standard of care at multidisciplinary visits. We see physical therapy, we see occupational therapy, we see the pulmonologist, cardiologist, neurologist, psychologist, but we're not seeing at every visit the dietitian. And most of our children that we see in clinic are either underweight, which are falling below that growth curve. And we see that a lot with our Becker kiddos. And then we have overweight, which are usually our Duchenne boys, just because they're usually a little shorter in stature. So their BMI is higher. So, there's really no reason that you can't make a case to see a dietitian. And I think that's one of the things that I really am trying to push, is to show our practitioners the need. And then also, if that growth curve changes, and then other ones to consider, is there changes in glucose metabolism, mobility, respiratory, and cardiologic functions. So the heavier they are, the harder everything else has to work. And that includes mom and dad and transitioning and things like that. And then it kind of leads into Kiera and Kent's discussions of the GI complications that happen with constipation of water and fiber, and then the chewing and swallowing difficulties. We have an excellent resource here at Children's that we have a psychologist that does feeding therapy, which is pretty cool. And then talking about the calcium and vitamin D deficiencies. And we talked about that it's very important. We're prescribing vitamin D, but sometimes we don't discuss that calcium. And then if we have these kiddos that are iron deficient, we're not going to put the iron isn't absorbed well if it's mixed with the calcium. So there's just a lot of things that a dietitian has the opportunity to sit with the parents or the family and discuss some of these other things we can do. So when to ask for help, the family has to be willing to make the change. But as we know, sometimes when a practitioner pushes an issue, parents will comply. So we all need to make the change. We think this is necessary, not, oh, you should maybe see a dietitian. Make it a statement. We need to set you up with an appointment to see a dietitian. This is imperative for your kiddo's health. And then make it as normal as possible. So, we talk about a lot in our family, make our kiddos do what they can do as they can do it. So this is chores, parenting styles. We actually just finished a research project on this. They have a very high permissive parenting style in this disease population because parents are emotional about their kiddos and they're emotional about what could happen in the future. So it's almost a free for all, like, oh, you don't have to do this. Oh, you don't have to behave. Oh, you don't have to do this because, I might not have you forever. So that's actually a very big hindrance on these kiddos and for them to lead independent, productive lives. Also, unlearning those unhealthy behaviors. So My Plate for us in the US is an excellent tool. I think that you guys should be able to use it as well. Stop that emotional eating. Stop using food as a reward or a punishment. We do this so much as a society of, if you don't eat all your dinner, you don't get dessert. It shouldn't be that. It's, there's dessert, but you have to eat your food. And then you can have dessert, but not if you don't. And then also incorporate participation and learning about nutrition. I will say sometimes teaching Tyler about nutrition and how important it is to eat healthy really bites us in the tush, because we will go and do something and he'll be like, that's not healthy. And I'm like, yeah, Tyler, I know. And he's now been telling his teachers, some of them are a little overweight, that they do not make healthy choices and they should not be eating that way. So we've had to have a little discussion about, there's a good way to say this and there's, maybe not such a good way, but deep down inside, I'm like, yeah, buddy, get them, like make everybody eat My Plate. So then that kind of goes back to being an advocate for your kid and your family. And that's a practitioner's job as well, is to be an advocate for their patient and say, we want you to have the healthiest, most productive life you can have. So we want you to do X, Y, Z. And then also encouraging families and as a practitioner that physical activity is okay. Let your kiddos do what they can to their ability. So basically, nutrition is one of the most important things we can do for these boys. We can do it early on. And if we do it early on, maybe we will see some other health issues that are related to this disease, maybe put at bay for a little bit. So I will wait for questions until the end, but this is my information. I'm sure that you guys are going to share your slides at the end. So that is all I had for that. So thank you for letting me present. Sorry, I was trying to go as fast as I could, guys.
Great. Thank you very much.
Thank you very much. Now I'm going to move to Dr. Williams from Nationwide Children's Hospital. I will make you co-host so you can share your screen. You're on mute, Dr. Williams.
All right, sorry, a little technically challenged. All right, so yeah, my name is Dr. Kent Williams. I'm a pediatric gastroenterologist at Nationwide Children's Hospital in Columbus, Ohio, and also associated with the Ohio State University Medical Center also. I've been working with children. Before I started working with kids with Duchenne's, I actually was working a lot with children. Primary focus is autism. And what was interesting to me is when I was asked to help out in the neuromuscular clinic with the Duchenne's population, it turns out that there's a high percentage of these young men that also have autistic-like features for sure. So I've been doing this for about 6 years, and what I'll be going over today is going to be primarily the focus points that I really try to work on with this patient population as soon as possible. One is bowel management, and the other one is the timing of a G-tube. So for bowel management, there was an article put out by my colleagues at Cincinnati Children's, just about 2 hours from here, where they looked at the rate of constipation and occurrence of constipation in this population. And what they found out was very surprising, I think, to a lot of us, was that there really wasn't a difference with the prevalence with age, because we would all thought that as the young men start losing their ability to walk and more immobile, that not being able to get to the bathroom, that would be the time when you'd have more of the constipation issues. And ironically, when you do think about some of the behavioral issues that go along with Duchenne's, it makes sense why you don't see a difference with age. Because as I was telling you earlier, I work with kids on the spectrum, and autistic-like behaviors make you very predisposed to having constipation. So constipation, the prevalence seems to be fairly constant throughout the lifespan of these young men. And what they did is they did, looking at the criteria for constipation, which we'll go over here in just a little bit. And they surveyed 120, and half of the 120 met the criteria for constipation, but only half of those who did meet the criteria were actually being treated, which meant roughly about 1 out of 4 of the kids had constipation and were undiagnosed and not being treated. And you ask, well, you know, hey, so it's a little constipation, it's a little poop. Well, I have to say, I, on about a monthly basis or every 2 months, will find a patient like this, where this is an x-ray from someone that I was told, oh, he has a little bit of constipation, some bowel issues, can you come over and see him? Yeah, I'll be glad to. I put one hand on his belly and I feel this very large, firm mass right in the midline, and I get an x-ray, and he is completely impacted to the point, this kind of light, darker stuff around it, he's practically almost obstructing himself. So it's not too uncommon, particularly if they've had a long-standing history of constipation and then become immobile, that the constipation becomes way worse. So try to teach my friends here, and actually one of my colleagues, some of you may have seen him at some of the conferences and things, if you watch things online, Dr. Shell. He refers to me as the poop doctor. It's adequate. But there actual are criteria for constipation, and you have to have 2 of the more following, and one is excessive stool retention. And this basically is their withholding. Is, do you see your kids? Because a lot of the times, and you just can't say, do you see your child withholding? Especially when they're ambulatory, the parents will say, no, he never withholds. Then they'll go on and talk and say, well, do you ever see him kind of do a little dance, or maybe, you know, squirm around a little bit, or maybe tighten up a little bit? And they're going, yeah, he does that a little bit. That's stool withholding. And then any painful or hard bowel movements, the consistency. Are the stools hard? Are they little balls, a little hard? Are they big, large balls, like big, kind of firm Play-Doh balls? And then that gets into history of large stools. And basically, I always ask the question, gets a little bit of a laugh and chuckle. Does your kid ever have what we call, holy cow, bowel movements? Or are you taking pictures of them and showing them to your spouse? Or do you just call the other person in the room? Oh my gosh, you gotta come here and take a look at this. This is huge. If you're having those, you're automatically going to be constipated. Large fecal mass in the rectum, as I was showing you, what it's not subtle. We're not talking about a little bit of stool there. We're talking very large. And at least 1 episode a week of incontinence. And that can be anywhere from a bowel accident to just having streaks and smears. And every time I ask this question, almost inevitably about 80%, 90% of the time, parents, oh, they're just not wiping well. Well, no, actually, if you have a large amount of stool in your rectum and the pressure builds up, a little bit's always going to be seeping out. And if you have at least 1 episode a week of that, then you're meeting a criteria for constipation. Actually, in the Rome criteria, actually asking the question, does your child clog the toilet, is actually one of the criteria also. And then frequency does play a role in it, but you can go poop 5-6 times a day, particularly if you have very large fecal mass in the rectum or a lot of stool in there. You can go 5-6 times a day and be severely constipated, but frequency comes in and plays a role when you have 2 or less bowel movements a week. So we make the diagnosis, and then what do? Well, then becomes the reluctance for treating. And the reluctance usually is, as Kindann was saying earlier about urination, it's the same for bowel movements too, particularly if the young men are having a problem getting to the bathroom, or if they depend upon somebody else, they do not want to have bowel movement. They're happy having a bowel movement once a week, but actually it will set you up for more and more complications. And the big thing is, if they're dependent on others to have a bowel movement, they very much don't want to have anything to try to make them have a bowel movement. So what I try to impress upon my patients is, look, I'm trying to improve your quality of life. I'm not trying to make you have a bowel movement, but let's work together and let's come up with a bowel regimen that not only keeps your colon healthy and prevents you from developing these obstructions and unwanted bowel movements, but try to make it better for you. And we do it from the very beginning, even before they come on, when you're ambulatory, because like I said, a lot of the behaviors are associated with Duchenne's makes them prone. So we want to start early so we develop good patterns that will then protect you when you start becoming non-ambulatory. And the goal, the ultimate goal is, I want you to be in control of your bowel movements, not your bowel movements to be controlling you. If you're worried about going out or worried about going to a family reunion or doing things because you're afraid of having bowel movements or going to school or things like that, we need to come up with something better to improve the quality of your life. And what are the treatment options that we talk about? Well, of course, there's oral laxative regimens, but the one thing I talk to other physicians about is daily stimulants. We are a motility center here. We see patients from around the world, and we've actually done the studies where you use Synacot or you use Docalax or Bisacodal is the brand name here in the States, but a stimulant to try to give you the extra impetus to use your muscles, to be able to have a bowel movement. And we try to use it in a time where we try to maybe use it every day or every other day to try to stimulate a good bowel movement to keep you from being impacted. And lots of people have always heard that if you go on a daily stimulant, that it's bad for you, that your colon gets lazy or you have an addiction to it. And we've actually done the studies here. That is not true. We use these almost as much as we will use stool softeners and as we use Miralax or polyethylene glycol. We use it very, very frequently, particularly in those who do have stool withholding behaviors at the very young age. We use it from pretty much ages 1 on up. And there are so many different types that you can use. And then if oral laxatives aren't doing it and they're having those really large bowel movements and they're happening at inopportune times, you want to start taking over and trying to time or be able to control when you have the bowel movement. Enemas are a good choice. I'll put kids on it, maybe not necessarily every day, but at least 3 times a week or so to try to keep that last part of the colon cleared out. And then the last thing that we've really been kind of pushing on over the last year is a surgical option, is a colostomy. Now, you bring up colostomy in the beginning and parents are just like completely almost, no, I don't want him to have a poop bag. I don't want that. But I think if we start implementing this early on, having discussions early on of trying to give people this is a journey. This is what is going to be happening with your child as this condition progresses. And I always try to stay away from words of disease and those kind of things. I think more of the things of condition and how we can make you function better in the daily functions and daily life. And a colostomy can be an invaluable tool for that. And we know that from other patient populations, such as those who have spinal cord injuries or born with spina bifida, that this allows them to go out and function and not have to worry about having bowel movements, because these kids it's hard for them to get picked up and put onto the toilets. And that's the thing that the reason I started really trying to talk to my parents about this more is because as they begin to lose more and more control, I can't tell you how many times I've heard it's difficult for him to sit. We dropped him trying to move him from the wheelchair onto a toilet or a bedside commode, or it's hard for him to get on a commode in the bed. Using a colostomy can drastically improve the function and allow you to do things without having to worry about dropping or being pain on sitting on the toilet, or being able to go out with your family without having to worry about where's the bathroom. So the other things that we always talk about when we start about surgeries too is G-tubes. And again, people start thinking along the lines, oh my gosh, he needs a G-tube. I have failed. I have failed. I've not been able to feed my child. Is part of it, I think. I really do. Plus, I think the other thing is people start thinking, no, I'm thinking it was a failure, but we're getting close to the end. And they're not going to. Again, if we start having these discussions early on, you will be able to talk to them again. This is an aid. When my pulmonology friend I was talking about, Dr. Shell, when he talks with his families, he starts talking about BiPAP, and it doesn't seem to be as much of a, a hindrance or avoidance of using BiPAP. Of course, it doesn't require surgery, but the surgery is not that invasive. And the earlier you do it, the better. And what we're doing this for is to be able to allow you to have good supplementary nutrition. We're not talking about taking away your eating. We're not talking about you're going to not be able to ever eat again. No, not unless you're aspirating and choking on every food that goes down. But we're talking about being able to give fluids. We're talking about give nutrition, and there's a lot of benefits for that. So the indications where I start talking early on, if they've allowed me, especially if I'm talking to someone about constipation, I always take an opportunity to talk to them about nutrition a little bit and how things are, what I'm thinking like from a bowel regimen and from eating regimen. And what I usually say is if you start having difficulty feeding yourself, if you're having problems bringing the food up, if you're having problems doing that, it's going to make it more difficult to get all the calories and nutrition in that you need. Now, I'm not going to prevent you from doing that, but we're going to do things that kind of give you a little bit of a supplement, a little bit of a boost. Unable to maintain your weight. Growth charts are vital. I don't want to wait until the kid looks malnourished to me. I want to start looking at a growth chart every visit and see if the weights are starting to slowly decline. If they are, we need to start talking about a G-tube. Of course, any kind of choking, any kind of aspiration, I always ask, do you start getting tired when you start to eat? Is it more difficult for you? Are you cutting up your food more fine and chopping and trying to avoid it? Once you start getting into those things, then I think we need to start talking about, again, being a supplement for you. And believe it or not, bowel management a G-tube can greatly enhance your bowel management, because if you're like that last young man that I showed you the x-ray of, we actually got him a G-tube fairly on too, because he was having nutrition issues right off the bat when I saw him too. And we're now using that because his colon is so dilated that we use that as a clean out. We give mini clean outs about every 2 weeks to him so that he doesn't have to continue to have build up and have unwanted bowel movements in between. And plus, you can give the extra fluid, because laxatives aren't going to work unless they have the fluid to hold on to. So the G-tube concerns, still able to eat by mouth. Parents get very concerned, or the kids get very concerned that we're talking about no more eating by mouth. That's not true. It's a supplement. The surgical risk, there's always going to be a surgical risk, but it's going to go up. It's not going to get better. And I've never seen a kid who starts to have problems eating, who starts to have a decrease in his weight, bounce back. It's going to help you, and it improves the quality of life. I have not had one patient yet that finally agreed to do it that comes back and saying, this was the worst thing I ever did. If anything, they always said, I wish I could have done it sooner, because they always talk about, like, man, I have a lot more energy. I can focus better. I can think better. I'm sleeping better. And believe it or not, again, like I said, if we're able to give fluids and give everything right, you're actually able to help with the bowel management also. So those are the focus points that I have for my talk. Thank you very much.
Thank you very much, Dr. Williams. Okay, now we're going to move to Kiera. Again, if you have any question, you can write them in the chat. Okay.
Great. Wow, thank you. I want to thank you guys so much for inviting us to come and talk. I think this has been one of the silver linings of this pandemic, is that we're able to do this, even though it's getting close to what would be my bedtime if I were there. But so we'll try and be mindful of your time. But so I'm Kiera Berggren. I'm a speech language pathologist here. I work at VCU Health in the neurology department, and I specialize in the neuromuscular population, and work in both our pediatric and adult clinics. And I am fortunate in both of those clinics to have a dietitian with me that, and we work hand in hand. So I'm lucky that way. And I'm also actually a doctoral student and specializing in dysphagia and swallowing disorders. So it's an area near and dear to my heart. Let's see if I can get this to go. Okay. So I've done similar presentations for the FSH Society. I'm a consultant for CPATH, and then no other disclosures. Didn't know if y'all needed that, but thought I'd throw it in. And I know some people may not be as familiar with some of the swallow stuff, so I'll kind of talk about what is dysphagia just in general. Even in some of the people on a couple of the clinic teams that I'm on, have some differing views of what dysphagia is. So I just kind of want to set the ground there, and then what does dysphagia look like in Duchenne, and then how can a speech language pathologist help with that? So I promise there will not be a quiz at the end of this, but I did like to put in here this side view of what we look like inside when we swallow. So at rest, normally the airway is open, we're breathing in and out, and that esophagus is closed up. And then when we go to swallow, a whole bunch of things happen, not the least of which is the airway closes itself up and moves kind of, the top of it kind of moves up and out of the way, the larynx. And the esophagus gets pulled open. When I see individuals that I'm concerned about swallowing difficulties, in my head, I'm thinking of where is the difficulty? Is it in the oral preparatory phase where that tongue is moving food around and in the mouth and helping get saliva on it, get it hydrated? Is it in any of the swallowing phases, the oral phase where you're bringing it back into the pharynx, the pharyngeal phase, or the esophageal phase? And in the back of my mind as well, I'm thinking, you know, how quickly is this all happening? Normally, it shouldn't take more than 10 seconds. It's often quicker than that for food to get from the mouth through down to the stomach. And there's quite a few pairs of muscles that are involved in this process. It's a pretty complex process, and timing is really important with this because we don't want food to be sneaking down into the airway. And so we do actually hold our breath when we swallow for up to a few seconds. And, you know, I appreciated the nod earlier about, you know, are people getting more tired? Are meal times getting longer? Total meal time, at least in the US, our average is about 20 minutes plus or minus 10. I don't get too jazzed about, but if we start getting to 45, 60 minutes, you know, that starts to be of concern to me, and it kind of perks up my ears a little bit. So kind of just some symptoms, because I think there's a lot of misnomers in the field, in the health field in general, of what is dysphagia, just in general. So when I'm thinking of the oral phase, whether it's the preparatory phase or the initiation of the oral phase of swallow, it's how easy can somebody move food around in their mouth? Do they have any anterior loss? Do they have any posterior loss? So it goes down into the pharynx before our airway is protected and the esophagus is pulled open and we're ready to swallow. Can somebody chew very thoroughly and initiate that oral phase of swallow when they're ready to? And then after, in my perfect world, when somebody swallows, all the residue in the mouth and the pharynx is gone. In the neuromuscular world that I work in, that is not reality, unfortunately. So I'm looking at how much residue is left in that, at least in the oral phase when I'm looking at, or the oral cavity when I'm looking at somebody clinically. The pharyngeal phase, I'm asking, you know, does food ever come up into your nose when you're swallowing? Is somebody doing a lot of coughing or choking when they're eating? If there's a lot of throat clearing as well, that can indicate that there's some pharyngeal residue. I'm listening for how their breath sounds, how their voice sounds, how many swallows they're taking per bite. And then a big one that I hear is, people may say food is stuck in their throat, and they may actually say that even if it's stuck pharyngally or even lower down in the esophageal area. And so I put that kind of in both categories. And then certainly if somebody's telling me they have any substernal pain or just pain in general when they're eating or feeling full in their sort of thoracic area, and if they can feel food passing, that's an important thing as well too, through the esophagus. And then I'm always asking as well about heartburn. We do have a lot of our kiddos also have GERD, and so this can be something that we want to pay attention to as well. And then again, that if their meals are slowly getting longer and longer and longer over time, that to me is indicative of they're having more difficulty, whether it's from a chewing point, a swallowing point, or anything in between. So for Duchenne in particular, we know, and I have references at the end of this if people are interested, but we know that tongue strength in these individuals decreases as our boys age, and there can be, we all have some changes in our morphology of our dentition as we age, unfortunately, but it can also be a thing as well, more exacerbated in Duchenne. So that can lead to more difficulty chewing. We do know as well too that the upper esophageal sphincter has decreased sort of resting pressure as these boys age, and that can result in difficulty getting into the esophagus. And so we end up with more pharyngeal pooling of food. Also with all the musculature in the cervical region that may be getting a little weaker as the condition progresses, that hyolaryngeal complex may not be moving up and forward as much as it normally should. And then as everybody's noted already, pulmonary function is a big area of concern with these individuals. And so if I see somebody that's having a lot of respiratory difficulty or on supportive ventilation or anything like that, in my mind, I'm thinking, how does their swallow look, knowing that they have to hold their breath while they swallow, and that can be more challenging on respiratory support. In patient reports, so individuals with Duchenne who have been queried about this, many will report that, or most will actually develop dysphagia, and they may feel pain, they may feel food stuck in their throat. They may even have more difficulty swallowing their saliva, coughing with meals, those longer meal times, difficulty, especially as the tongue gets weaker with age, of initiating that oral phase of swallow. They may not feel as hungry anymore. And of course, that unintentional weight loss that Kent just mentioned as well too, that's a big sign. And I'm fortunate, like I said, in my 2 clinics that I'm in, I can often go in with the dietitian, and we go in together and say, is the weight loss nutritional? Are we not getting the right supplements? Are we not eating the right foods? Or is it dysphagia? They're just having more difficulty, or is it both? And oftentimes it's both. So we approach it from 2 different angles, and then certainly get GI involved as well too. If our young men are having increased frequency of respiratory infections or choking episodes, certainly those are indicative of dysphagia as well too, potentially, and need to be looked at a little more closely. So as a speech language pathologist, I just kind of want to give a quick overview of how we can help, because I think a lot of times people think, oh, they just help with speaking clearly, and swallowing is a big part of our practice, especially I think for SLPs that work with Duchenne or other neuromuscular disease. So my job is to come in and say, what's the specific concern? And I may do a swallow assessment with these individuals, and I really like to stress these are not pass-fail. It's not a binary world that we live in. It's really a chance for us to sit down and say, whether it's through a clinical swallow evaluation where I'm in clinic watching them eat whatever snacks they happen to bring during their clinic visit, I'm looking at kind of what's going on and how we can really safely sort of support them as they're eating. We may go the route of a modified barium swallow study that goes by several different names depending on where in the country or the world you are, but that's really going to radiology and seeing an x-ray video from the side of how things are going as we eat food that's coated with barium. And that can be a nice one to do in conjunction with GI as well too, to really look at how that esophagus is functioning for sure. Or we can do a FEES, a fiber optic endoscopic evaluation of swallow, where we're really looking with a camera up through the nose and into the throat, what's going on as the person's eating. And that can be done in clinic as well too. So one thing I like to do when I do any of these studies is really sort of play with strategies real time and see what helps, what makes it easier or safer for an individual to eat. So I think one of the biggest hats that I wear in clinic is really helping along with the dietitian and certainly the neuromuscular physician. What are the goals of nutrition? What do we want out of all of this? You know, if somebody wants to remain PO forever, they absolutely do not want a feeding tube. That's okay. We're not going to force them to get one, but we also have some discussions about how to make things a little bit safer. And I always like to stress that a feeding tube doesn't, again, not a binary world. We don't just eat by mouth or just eat through the feeding tube. I would say most of my patients echo exactly what you said, Kent, where they're saying, gosh, I wish I had done this sooner. It's making it so much easier and to support nutrition. And I think there is a lot of the psychosocial component to it as well, too, that we need to consider more. But you know, again, individualizing those strategies, whether it's using adaptive utensils, and I've listed a few in here, or working along with the dietitian to figure out what are more higher calorie foods that are going to help support their PO nutrition, working with our occupational and physical therapist if they need trunk support or upper extremity support, so when they're eating, they can continue to feed themselves. And then really supporting that oral hygiene piece. We know as well that individuals, even if they're completely NPO, if they're not cleaning their mouth, they're still getting aspiration pneumonias at a much higher rate than the general population might be. So I always talk with my patients about cleaning your teeth, flossing, limiting sugary snacks. That's a little bit harder for some of us to do. And then certainly visiting a dentist as well. And I leave it to the dietitians to set those boundaries on sugary snacks. But, some kind of general tips for safe swallowing that can be used for any of us, you know, and certainly with our Duchenne kiddos, especially if there's more scoliosis going on with them, is being really upright to make sure that we're in a good, safe posture, supporting that trunk, or as I mentioned, the upper extremities, smaller bites, smaller sips, you know, alternating food and liquid to make sure we're keeping things pretty well hydrated as we're trying to swallow, or moistened while we're trying to swallow. For some individuals, using a straw may be of help. That doesn't work for everybody, but it can work for some individuals and really help kind of keep that chin in a good position so we don't get premature spillage going down into the throat because we're tipping our head up. So that can be useful. Meals tend to be very social times. Limiting distractions can be helpful for some individuals so that they are able to focus on the task at hand. And I tell people, you know, as best as possible, please try not to talk with food in your mouth. We all do it. We've all been guilty of it. But moistening those foods, making them softer, a little bit easier to eat. Taking pills in a different form. If somebody has a feeding tube, certainly putting them in the tube is going to be safer. But if they're fully PO, then, you know, maybe take it in a bite of puree or crush it if the pharmacist is okay with that. And take it in, you know, yogurt, pudding, hummus. I've told people soft bananas, any of that. And then also, if you see somebody with a lot of residue in the mouth, ensuring that they can swallow additional times to clear before they put more food in. And I will often tell people, we know in our little babies and in other disease populations that we really want to limit meal times to about 15 to 20 minutes so they don't tire out. And I'm really starting to push this with all of my kids that have dysphagia and my adults. I work with motor neuron disease as well too. So really saying, you know, maybe about 20 minutes max for meal times, and have more frequent meals during the day. And then working with the dietitian to say, what are some good snacks, as Kindann mentioned earlier, of, you know, making sure we're getting some fiber and some protein in there as well. Or, you know, if it's a day that they really want to have something that might be more difficult for them to eat functionally, do it earlier in the day when maybe they have a little bit more energy, or earlier in the meal. I had put some ideas on here of things that are a little bit softer to easier to eat, as Kindann mentioned as well too. I never want my patient or the individual I'm working with to stand out at the dinner table. Everybody should be eating the same thing. We're all in this together. And so really, I think the overwhelming message from me is really to manage that situation so we're as safe as possible while we're eating. So, some references, and then my contact info and a picture of the town I live in. And feel free to contact me directly if you have other questions, but I know we have question time now if people are still awake enough.
Thank you very much. It was very interesting. I think we have a lot to learn, and just to be aware of all the things you talked about. It's very important to know to ask the right question and to notice these little things that you talked about. Can be very helpful, can help to prevent complications, and sometimes, you know, just to give a few little tips and behavioral stuff you can do can make a big change. So it's very important, and of course to give treatment if needed during the progression of the disease. So it was very, very interesting and important. Now we have 2 questions, I think. Let's see.
Yeah, it looked like that probably more for me. What study you need before a gastrostomy tube? So typically, I don't put in the gastrostomy tubes because, I mean, I can do PEG, or me and my colleagues can do PEGs, but I typically go with a surgeon who will put in a low profile right away, and that often can also suture it to the stomach up to the wall, so we can go straight to a low profile and have a little bit better compliance, a little bit better quality of life immediately, as versus a PEG, which kind of usually the tube will stick out for at least 3 months or so, and then you got to go back and get it replaced once the tissue is healed. So typically, I know for my surgical friends, particularly, we'll get an upper GI to make sure the anatomy is okay, that we're not missing any kind of outlet obstruction or any problems with anatomy. If there is signs or symptoms of, say, vomiting, abdominal pain, bloating, that we are worried about the motility of the stomach, we will sometimes get a gastric emptying study. One of the options we go with here, though, if we feel like we can't use a G tube and a kid is vomiting and bloating, I mean, that's a different scenario than someone who's just kind of slowly going down, is tolerating feeds, doing well with it. If you're talking about a patient who's actually having signs of gastroparesis, sometimes what we've done is we go straight to a GJ, and we'll use a GJ that has both a G port and a jejunal port. And that gives us the option, if the G isn't working, that we can go straight into the small intestine. Now that means continuous feeds, though. You can't do bolus feeds through that. That is one of the options we will do, though, in another scenario where if a kid's not getting enough in during the day, they're on BiPAP at night. A lot of times we may go with a GJ versus doing a fundoplication, depending upon their clinical status, so that you can do a continuous drip at night. Now, that can be a little risky because GJs are notorious for flipping back into the stomach if you don't have the niacin. Then we worry about aspiration and things at night with the continuous positive airway going in and putting maybe more stomach in there. But those are so long story or long answer, but short answer is minimum an upper GI is usually what we'll get. If there's signs or concerns for gastric emptying, we will maybe get a gastric emptying study. And if they're in the really severe cases where they're not tolerating any feeds, we may just go straight to a GJ.
Thank you.
Yeah, I have two questions. One is, do you change the nutrition recommendation based on the disease progression?
Kindann, you want to?
Yeah, so it's kind of, you know, I hate to say this, but it's like, it's all dependent on the individual. You know, maybe the modality of eating, like we were just talking about, whether we go to a tube feed and then we're doing a specific like compound that's already formed, or if we're blenderizing our own feedings. But the actual nutrition, like what they're going to need, is dependent on the person. So like how many macronutrients, so how much protein, how much fat, how many carbohydrates they're going to need is going to be very different for somebody that is further along in their disease and can still eat by mouth, and then somebody that can't eat by mouth. So I think that that's more of a individualized question of specifically like, give me, you know, I would say like, give me the example of who it is, and then we can discuss things. But like changing just from like, do you need to eat meat in the first part and no meat in the second part? No, nothing like that. You know, we all are going to need to keep those nutrients, you know, and I think, I mean, as differing types of, you know, like of an organ failure or something, if we were looking at something like that, yes, possibly like go to more of a renal diet, fluid restriction, things like that, if that were the case. But just to give a blanket statement, it's more individualized. Sorry, I hope that helped.
Yes. And for Dr. Williams, when you diagnose the constipation, are there nutrition changes that can be done before adding medication?
It depends on how severe the constipation is. If it's pretty mild, I mean, you know, we might do, it's not great nutrition advice, but sometimes we might use a juice or something if they're really afraid of using or kind of reluctant to use laxatives. And I would pick something that's got a little bit more sorbitol in it, pear, prune, apple, those kind of things. The big thing would be fluid. If the kids are trying, particularly those in a wheelchair, if they're trying to cut back on their liquids because they don't want to go to the bathroom as much, then, you know, I've got autistic children, they only take 4 ounces of fluid a day. That's all we can get them. You know, those kids, that kind of scenario, it doesn't matter what laxatives you give, it doesn't matter what sorbitol or juice you give. If it's only 4 ounces liquid, you know, it's not. So I always make sure that I get a good dietitian involved, because as Kindann was saying earlier, MD stands for medical dummy in certain situations. And when it comes to giving dietitian and nutrition advice, it's definitely a medical dummy. It's best to give somebody who really knows what they're talking about, particularly when it comes to fluid management and things like that. I'll get a good dietitian involved. We'll make sure that there's plenty of fluid. Now, going to the other types of, you know, issues with diet, you know, getting enough fiber in and those things, that, I gotta be honest with you, the studies are kind of mixed on that. And some people giving more fiber actually make you more constipated. Others, we give fiber supplementation and they do well with it. So the thing I really focus on the most is the fluid. And then we go from there.
Thank you.
Do you have a lot of experience with metformin? Because here I think we don't use it a lot in Israel. So
I'm sorry, a lot of what?
With metformin.
Oh, metformin.
Yeah.
I bet we all do. Mixed. It's not anything that's going to really drastically change your weight if you're not doing the dietary component with it, is how I feel. I'll let Kindann and Kiera take that from there.
Yeah, that's actually a really good question. We talk about this in clinic all the time. It's kind of one of those things that, does the metformin really work, or does it just make the kiddo feel not very good and they don't eat as much? You know, because I mean, there are some pretty significant symptoms, issues that can come with taking it. You know, your belly hurts, you might have diarrhea, you might just have like just an upset tummy. And then, you know, if you're not feeling like that, are you really going to eat? And I think, like Dr. Williams said, we really need to look at nutrition on the get-go. You know, we don't want to just tell you to take a pill and then eat whatever you want. You know, that's not the goal. And I think sometimes in our world, that's the easy fix. It's, oh yeah, just give me metformin. That's great. And then I'll just continue to do what I want to do. And then now you're not pre-diabetic anymore. Now you have full-blown diabetes. So I think it's about, you know, education. And I think for the most part, we don't want to put these kiddos on more meds if we can keep from it. If we can do something on the front end, yes, let's do it on the front end to prevent that. But if it needs to happen, it can happen. I will say there are quite a few of our kiddos in clinic that are on it because they're in the like obese category, and their blood sugars are not stable, and they have high A1C and things like that. But it's kind of that, were we too late? You know, could we have changed something on the front end? And I don't know, what about you, Kiera?
Yeah, I would say we see the same thing in our clinics as well too. It's really, we try and get in there, and, you know, I think all three of us are saying the same thing: engage us early, engage us, you know, even before there's possibly a need or a perceived need, because there's some things that we may be able to help pick up on that can head some of these other larger health consequences off down the road. So yeah, but I don't think we see a ton of great luck with the metformin necessarily. So yeah.
Thank you. I think all these fields should be put more on the table and talk about it earlier and in younger ages. And it's very important to just raise it up and raise the awareness regarding it. And sometimes there is some avoidance from things like the tube and things like that. But if you try it more and you can see that it really improves your quality of life. We have two more questions in the chat. Aggie?
Yeah, I do not recommend antibiotics for trying to change flora. The field of intestinal flora and how it affects medical conditions, I feel like, is very much in an infancy stage. I for sure do not recommend bowel or fecal transplants. And I get a lot of that questions in my autistic population, because giving antibiotics has significant side effects, significant risk, not just long-term as maybe developing a drug-resistant bacteria, but in the immediate. There can be anaphylactic reactions where difficulty breathing. There can be the worst one I've seen in a kid that I treated a known condition. I put him on antibiotic and he developed serum sickness, where he was miserable for 2-3 weeks and in the hospital for 2 weeks. So they're not completely benign. So I definitely do not recommend antibiotics. As for trying to change the flora and whether probiotics are worthwhile, there's no good studies, I don't feel like, that are slam dunks that doing probiotics really works for across the board for everybody. And that's including neurotypical and healthy individuals who have irritable bowel syndrome and those things for belly pain and stuff like that. However, taking a probiotic that comes from a reputable company, and that can be a risky thing too, because probiotics are usually not regulated by a government agency. They're more or less considered a supplement, additive. So I even did a research study in autistic children of giving a probiotic that I thought was very reputable company. A year after we finished the study, we get a letter from the company telling us that the previous CEO had altered the makeup of the probiotic, and we were not giving the probiotic we thought we were. There was different bacterial strains in them. They'd never really been studied before, yada, 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 yada. So with that being said, it's kind of a buyer's beware, but I don't necessarily prevent my families from using probiotics, because if it works for you and you feel like it's helping, I don't think there's a high risk in it, but realize it's kind of like doing a vitamin supplement. You don't know for sure 100% what you're going to be getting. And there are no great studies saying that for sure this needs to be done.
Okay. Okay. I just wanted to thank all the experts who talked, and I'd like to mention our perspective as adults with Duchenne. A lot of what you said is, it seems like it's correct for like the younger stages of Duchenne, and we as adults seem to be dealing with conditions that are kind of not documented or unknown, and we try to solve things as we go. And as of my old age relative to people with Duchenne, I'm 39 years old. There's a lot of unknowns with what we are dealing with. So any small tips that you experts can give us, it's really appreciated, and it's very important. So thank you.
Well, and I would just like to say thank you, because, you know, as mentioned, we are talking a lot about children. And so your perspective is so important, and getting your information out there and telling us, you know, hey, what has worked, what has not worked, and, you know, being there for, again, even other patients with Duchenne, because, you know, I have a son that doesn't know a whole lot because he's not prepared to understand. So having resources like yourself that people can reach out to and speak at different conferences and give us the perspective of living a full life with this is amazing. So thank you.
Which one? Just a second. I have a suggestion here, right? One of the kind of pills that I'm taking to help with the motility of the intestine, it's I have to see the name in English. So just a second, she will bring the pack, but this is one thing that helped. And one thing that I especially suffer is a lot of gas in the intestine, which is hard to clear. So any tips about that will be good. The pills are domperidone.
Yeah, that's a pill that's not available here in the States, but it's very good. In fact, it used to be, and we used to use it all the time. So it's a great one, particularly as you are using it primarily for the stomach and upper part of your.
Yes.
Yeah. That's a fantastic medication. It got pulled off because there was a certain amount of people who had heart conditions that, you know, I can only use it in severe cases, and if I have what we call an IRB, approval for research, then to do it. Yeah, no, that's a very good one. I highly recommend that one. I'm seeing you have the SIP assist. I would say that probably adds a lot to the air in your swallowing and stomach. Actually, G-tubes is one of the things we will use a lot for that. So one of the things I'll do is if I have someone who has severe, what we call aerophagia, air throughout the stomach and then small intestines, and it's causing a lot of discomfort, maybe nausea, vomiting, things like that. A G-tube can be used for that. And what we'll do sometimes is put what's called a ferro bag or like a drain to the G tube. And it's kind of like it just constantly siphoning off the air as it goes into the stomach. Because once you get past the stomach, once the air gets past the stomach, there's not a lot I can do.
Yeah.
You can use a lot of gas pills, but gas pills don't necessarily remove the air. What they do is they take a big bubble and make it a bunch of little bubbles. Sometimes instead of having one big bubble trying to get through the intestine, you have a bunch of little ones, they'll go through easier. So there's no real upper limit of gas pills. Tell somebody what makes you feel good and stop when you start feeling kind of bloated from that. But G-tubes, if it's really affecting someone's quality of life, again, to me, the things, I never want to give a treatment that has a side effect that makes, that's worse than the actual condition, so to speak. And a G-tube is a very simple thing as long as you're in pretty decent nutritional health that has a lot of opportunities for someone who gets to age 35, 39 for different things. And one of them for you could possibly be, again, you'd have to talk with somebody, get more details of helping with aerophagia.
Okay, thank you very much. And thank you for all the other tips and your expertise, everyone.
Right, so thank you very much. Really appreciate your participation and your speak and
your time during the weekend.
Yeah.
Well, you guys are staying up late, so unless, I mean, in Israel, does people not go to bed usually until midnight anyway, or?
Too early.
Early? Yeah.
Now
I know, if it was an 8:30 our time, I would have been in my pajamas.
Yeah.
So,
it was a pleasure. Thank you so much.
Yeah, thank you.
Yeah.
So thank you very much. We have your contact details if one of our audience will want to have it. So thank you very much for your time and for your presentation and for your knowledge. And have a great day. Have a great weekend. Thank you.
Thank you.
Bye.
bye.
Bye-bye.
Thank you, everyone.
Bye.